that way anyway. All right. Well, we expecting any more on the student side?
There's classes end at 5:30, so I told them you can either do it via Zoom or come with me, either's fine. I didn't show up, so.
Yeah, we'll give it a few minutes. It's not yet 5. And we've got 10 people presenting. And we'll go from I'm going to close my Outlook so we don't get that here. Good. Close that window.
I'm not seeing the slides anymore.
Yeah, okay, I have to share those. There we go. Is that better?
There it is. Yes.
Resume the. All right, so now that I've gotten all my technical challenges out of the way as a non-information technology person, I want to welcome everybody to this radiology research opportunities workshop, really designed for you in the medical school. And I want to thank the medical student interest group for really sponsoring this activity. Our hope is that we can connect the medical students to the radiology department's researchers to help you get opportunities for doing work that, you know, builds your resume and gets things done and gets you interested in radiology research, so that those of you who are interested in radiology can really start to flourish in what we do as a discipline. So as a general format, what we're going to do is I'm going to go through all the faculty presentations really quick, and then I'm going to leave this Zoom meeting open for open discussions. If we're in the room, we can chat with you individually about our projects. Those on Zoom can stay on Zoom, and it can be a more of free-for-all, you know, last man standing kind of discussion. So, and then after we're all done, Bennett's going to take us on a little tour of the Research Imaging Center, which has the only PET MR in the Rocky Mountains and another PET CT scanner, and it's really a place for doing really interesting imaging research work. So, there we go. Click. All right, I'm going to. All right, so we're going to start with Dr. Ho, and here is his presentation, who we pre-recorded.
Hi, everyone. Welcome. This is Dr. Dong Ai-Huo, and I'm a board-certified medical physicist and assistant professor in environmental radiology. I'm sorry I could not attend the meeting in person, but I would like and happy to introduce myself and my research topic. And
we're not seeing the screen.
To contact me later through email or through the phone, and we can have a further deeper discussion. So first of all, I want to let you know that medical physics.
Can you see it now?
Is a subspecialty in radiology.
Right.
And usually we have background of PhD instead of MDs, and then we take care of radiology equipments in terms of the image quality, in terms of the patient's radiation dose, and our associated regulation issues. For myself, I get my PhD in biomedical engineering from Case Western Reserve University, got my residency in University of Florida, and joined University of Colorado since 2017. My research interests are mainly focused on the imaging informatics and artificial intelligence. And then for this particular research topic, I'm trying to understand how statistically the health tilting position are going to affect the patient's radiation dose. So I think, as you can see on the right, this is the typical CT health had position that we required our technologists to apply when they scan a patient. That the head is slightly tilted, and then when we scan it, we will scan in a so-called true axial way of the brain. In some cases, that the patient's head was not tilted due to some limitations. In those cases, the scan is in a kind of oblique situation. So, in addition to the impact on the image quality, and how this position will impact the patient dose from the CT scanner. And then we are going to study that in using AI as a tool. So if you're interested, you are going to kind of actively participate into this IRB approved research project. You will probably need to collect and analyze the data from the text where we store all the clinical images, and from the EPIC where we store all the patient information. And then you need to work with the technologists for the data annotation. I don't know how deep you understand the machine learning, but for most of the artificial intelligence, we need to train the model or train the computer to know what we want them to do. So data annotation is the important parts of that. And after we get everything ready, we need to code usually in Python language so that we can do an image analysis. And then we apply the image analysis code or the tool that we wrote to a bunch of the data we collected from the text. And then we do statistic analysis and get our conclusion. So we are looking to first write an abstract presented in a conference, and then finally put it into a manuscript and publish in a peer-reviewed journal. All right, that's all I want to introduce for this research topic. Of course, if you're interested in artificial intelligence, imaging informatics, and want to work on some other projects that you are interested, just feel free to contact me. We may be able to work that out.
All right, great. Let's see if this works.
Hi, everyone.
Did the same thing again.
This is
Let's see. There we go. So Tim, you're up. I can advance your slides for you. Just ask.
Just have one.
Yeah, okay.
Hi, everyone. I'm Tim DeGrotto. I joined here at Radiology last October from Mayo Clinic, and I'm directing the CURIC over there, although I'm at home at the moment, joining you. And so my background is I have a PhD in medical physics, and I've spent my 30+ year career mainly in PET imaging and mainly developing PET radiopharmaceuticals. I've done some work as well as cyclotron, isotope production, and radiochemistry. I've done a lot of work with metabolic imaging for many years in the heart to look at myocardial metabolism, how that might be useful for looking at heart failure, post-myocardial infarction, et cetera. And later, I did a lot of work with metabolism and cancer, looking at the lipid building block choline as a measure of neoplastic aggressiveness, and took that all the way to imaging of prostate cancer, where it's used around the world. That tracer is being supplanted quickly by PSMA, which we're getting going here. But as part of this research, we did do some studies in liver, even as early as 20 years ago. We knew that with the trend in the population of overweight and obesity, type 2 diabetes, the liver plays a very important role in metabolism and the etiology of these metabolic diseases. And I had developed a tracer for fatty acid oxidation in liver. And I continue to be interested in that area, especially how imaging might be able to play a role in non-invasively determining the transition from fatty liver, which is rather benign, although it's heading in the wrong direction, into inflamed liver, or NASH, which is non-alcoholic steatohepatitis, or NASH liver. So what sort of imaging approaches we could develop to look at that transition, which would be very important because in terms of knowing where the patient is at in the progression of metabolic disease, NASH liver is very important. So I want to present the opportunity that you could work with me and do literature research, because this field is moving quickly. The importance has meant that a lot of people have jumped in and are doing research in this area. What are the biochemical pathways that are involved in the progression of metabolic disease in liver? And would like to propose we would do a literature review on, and with the eye of looking at what new metabolic targets we could look at for imaging, which would be also related to therapeutic targets as well, because oftentimes those metabolic steps are used by pharma to develop inhibitors, et cetera, for that. Because we have the PET-MR, and it's a great tool. As you know, MR is sort of the gold standard for quantitative imaging of fatty liver. And so we can have the MR acquisition at the same time as a PET probe. And so we'll also look at the literature of how the MR is being used in liver for looking at fatty liver or even beyond fatty liver. And I think the goal would be to write a review article and, at the end, give some perspectives about, where we are in the field and where we could go from there. And could also direct our imaging research and maybe propose new targets to look at for this important area. So my contact information is at the bottom here. Would love to hear if you might be interested in working with this. Thank you.
Great. Thanks, Tim.
Yep.
So I think next up is Dr. Barker. So come on up, Alex. I'm going to raise this up so you can actually talk into it.
Yeah, hopefully I don't blow people away. I know we cranked up the volume here. Well, so thanks for being here. And I don't know if we have other people online virtually, but my name is Alex Barker. I'm the director of what we're calling the Advanced Imaging Research Program. And we run a lab called the Advanced Imaging Lab, which focuses on advanced imaging with an expertise in MRI. This particular project is both a collaboration between myself, I am an associate professor of radiology, and doing research with a PhD. There's a partnership with Dr. Lorna Brown. She's the director of pediatric body and cardiac imaging. So it's a great kind of collaboration between our research faculty and clinical faculty. And this particular project is a retrospective project. We've been collecting a large amount of data. It's already collected. It's IRB approved. So we're at the stages where we're looking for an organized student to look at Fontan-associated liver disease. What does that mean? Well, the Fontan circulation is the end result of a series of palliative surgeries in the presence of congenital heart disease, where these patients end up with a single ventricle. That single ventricle, essentially the venous return is short-circuited past the right ventricle into the lungs, and then the left ventricle or the right ventricle is essentially pumping out to the systemic circulation. It's amazing, these patients are living late into their 30s and 40s, but now we're starting to see additional complications such as liver disease. We want to understand, without doing biopsies, which of course are highly invasive and unpleasant, whether or not we can use some of our advanced imaging strategies to do a virtual biopsy or find CMR or ultrasound biomarkers. We're modality agnostic. I do like MRI, of course, but whether or not we can use some of these imaging biomarkers that we've collected to correlate with pathological grading of the liver biopsies that we've collected. So it's a pretty multidisciplinary project. You will not be working in isolation. We have a number of PhD faculty and as well as our clinical faculty to assist with this. We have statistical support, and should any advanced coding be necessary, we have a postdoc that is available for purposes of this project. So the expectations here are really to drive the analysis, not necessarily all the development of the analysis, but drive the analysis of this data that we've collected. And potentially, of course, the intent is to submit abstracts and ultimately publication. So with that, my contact information is below. Please feel free to reach out. And yeah, I look forward to hopefully talking with some of you guys.
All right, next up, we've got Aaron, Dr. Anglin.
All right, thanks very much. Nice to meet you guys that are here. I am Erin England. I'm an assistant research professor in the Department of Radiology. My background, I have a PhD in bioengineering with a focus on MRI methods development. So that's both acquisition strategies and then post-processing and analysis strategies to try to get quantitative information from the images. And we have a number of different studies that are looking at kind of microvascular function with MRI. And this one in particular is looking at placental function. So similar to the study that Alex described, it's retrospective. We've been acquiring data already and it's IRB approved. Our primary clinical partner is Mariana Myers, who's the director of fetal imaging over at Children's Hospital. She's a clinical radiologist. And what we are trying to do with this imaging method is essentially to try to quantify blood flow and oxygenation heterogeneity across the placenta in a variety of different patient populations. So we've done some preliminary analysis looking at patients with intrauterine growth restriction, twin-twin transfusion, and placenta accreta. And so we have, this kind of large clinical database, and we're hoping to try to get some of that quantitative information teased out of those patient populations. So we would be looking for someone with some image analysis interest or experience. That would be ideal. A lot of these tools are written in MATLAB, and kind of similar to the project Alex described, it's not necessary that you would be able to write that code, but if you kind of had some troubleshooting experience, that would be ideal. So we'd be looking for someone to perform some image segmentation. So this is just some example images of types of images we can, or parametric maps we can get of the placenta. So this is showing something called intravoxel incoherent motion MRI, where you can quantify the perfusion fraction and then kind of the speed of blood flow in the placenta. And then this product of F and D star, which kind of relates to the blood flow across the placenta, and then the diffusion coefficient D. And then ultimately, the goal would be to have you guys contribute to abstracts and papers. And my contact information is below. Thank you.
We're hitting you with too much at once. So next I have Dr. Callan. You on, Andy?
Yep.
Okay, go ahead.
Cool. Well, thanks. Yeah, I'm Andy Callan. I'm one of the clinical neuroradiologists here. I've been here about a year and a half. I think this is a great event. This is the way I got interested in radiology, was by participating in research projects as a medical student. I think it's uniquely hard to get exposed to our field in a hands-on way. So research is a very great opportunity to do that. I have a number of research interests, and they're all sort of born out of clinical curiosity that I've developed while taking care of our patients in the hospital. My current major focus in research is a study I'm leading evaluating patients who've had COVID for underlying cerebrovascular disease. So this is kind of dovetails off of previous work I've done in the HIV population, but we're using Diamox, a drug to perform vasoreactivity testing in the brain using and measuring it with MR perfusion, and also performing arterial wall imaging in these patients. This is an IRB-approved study. We're currently enrolling subjects. We've enrolled about half of our total number. So, in terms of getting involved with this project on itself, there will be a lot of work to be done in terms of analysis and looking at our data once it is collected, but also eventually, depending on our preliminary data, to both write up and think about as fodder for a larger grant application, depending on what we show. More broadly, so the projects I've participated in and papers that I've been a part of, I really enjoy looking at informatics in radiology and evidence-based medicine and resource utilization. We recently submitted a paper looking at the difference in positivity hit rate for head CTs out of the emergency room, whether a mid-level provider or an APP or versus an MD orders them. So those sorts of questions. Other kind of examples of that. So just these are things that I've discussed with my colleagues at the workstation that we want to think about. For example, when a patient falls as an inpatient on their way to the bathroom, it's a witness fall, they undoubtedly get a head CT because they're worried about an intracranial hemorrhage. But very rarely do we actually observe these to be positive. It'd be interesting to look at the utility of that order, which seems to be reflexive in the clinical setting. Additionally, we noticed a pattern that in domestic violence cases that come to the ED, almost all of them seem to get a CTA of the head and neck, CT angiography. So it'd be very interesting to look back and see, what is our positivity rate here? Is this an evidence-based approach? What are the costs and benefits here? And we have the resources and tools to ask these questions in a legitimate way. So I'll move on to my next slide. So one of my major clinical areas of interest is in CSF leak and CSF venous fistula. So I'm very excited about this. Anybody who knows me clinically will know that this is something I love to work on and talk about. And one of the reasons is that it really has evolved so much in really the last 15 to 20 years, our understanding of this disease process, and it's continuing to evolve. So there's so much we don't know about what causes people to have spontaneous intracranial hypotension. That is, the CSF that surrounds the brain and spine is leaking either by way of a hole or through an abnormal vein. So we are, in the process consistently of trying to find new ways to discover these leaks and new ways to treat them. We're currently looking at, we have a grant application in process to look at, what is the role of empiric therapy versus therapy that's based on finding a specific leak in the spine. But we have other ideas in the pipeline, including using some MR sequences that have been done at other groups to estimate spinal fluid pressure without having to stick a needle in somebody. These are all things that, as well as some more kind of evidence-based questions, for example, and kind of, informatics questions, for example, is there equitable access to CSF leak diagnosis and care across, socioeconomic guidelines, lines, et cetera, are there disparities there? So the really opportunities are endless here. And then finally, one interest I've had is again, born out of just working as a clinical radiologist, is that as facial feminization surgery for gender affirming surgery for transgender individuals has become more widely performed across the country and certainly across the world. We've noticed as neuroradiologists that CTs for this procedure have come across our desks. And I was a part of a team that wrote a paper last year trying to answer the question of how can we as radiologists provide value to these exams other than just saying, I don't see a fracture here, but that's obviously not what they're asking. So we looked at the specific cephalometric characteristics that go into changing a face from masculine to feminine for the purposes of amelioration of gender dysphoria. And while our prior paper and work was descriptive, I think it'd be very interesting to associate those characteristics and the measurements of change with actual patient satisfaction and outcomes. We have a very strong group of transgender medicine here at the University of Colorado, and they are definitely willing to participate in future collaborations in this regard. So yeah, so that's kind of the scope of the things I'm interested in. And certainly if you have your own project, I always say that the best project is the one that you're passionate about. So if, just something that you can get your hands on with in clinical radiology if you're interested in applying to our wonderful field. So my contact information is there at the bottom, and please don't hesitate to reach out to me personally. Thanks.
Great, thanks, Andy. Next to Dr. Carballo Gaimo. You on?
Yeah.
All right, excellent. Just tell me when you want to advance.
Okay, thanks. So I am Julio Carballido Gamio, and I am an assistant professor in radiology, and I'm doing mostly musculoskeletal imaging research. And I have like 3 or 4 projects that you could play a role on them. And I put them in decreasing order of complexity in terms of the technical skills that are needed. The first project is called the voxel-based morphometry of the lumbar spine. So a brief background about this project is we have it working for the proximal femur. This is a technique that is a neuroimaging technique, probably you are aware of it, to compare gray matter at corresponding anatomic locations at the population level. We adapted this technique, the VVM, to QCT studies of the proximal femur to perform statistical comparisons of volumetric BMD at corresponding anatomic locations and identify the regions that are where the bone mineral density is significantly different between 2 groups of subjects or the same group of subjects at 2 different time points. And the pipeline for this voxel-based morphometry, it is depicted here. Like basically you have a template that is your reference shape, and then you have all the QCT scans of the proximal femur in this example in your study. And what we do is we deform the proximal femur of all the participants in the study to match the outer shape of the template. And the output of that then basically is that you will have all the QCT scans with similar outer shapes, but with their own internal distribution of bone mineral density values. And then we perform a statistical comparisons at each voxel at each voxel, and we get a student's t-test map that tells us where those the location of the voxels where you identify significant differences in BMD. Now we have to do this for the lumbar spine. We got funding for a study, and we want a student to put their hands and do this pipeline, adapt this pipeline for the lumbar spine. And this person will be basically just adapting my code, that is a MATLAB code, to do the 3 main steps. If you could click once, please. So the 3 main steps would be, you would have to do the segmentation, you would have to do the registration, and then the analysis on a voxel by voxel level. And could you click one time, please, to see if it moves to show the.
There you go.
Okay, so thanks. So yeah, so those are the steps of this pipeline that you will need to do. So try to adapt the segmentation to make it as automatic as possible. It doesn't have to be automatic, but we want to save time to segment each vertebral body from the lumbar spine. Then you will use the registration software that I have to perform the spatial normalization of the vertebral bodies to a common template. And then you will use my tools to do the voxel-based comparisons of grade level values, in this case of bone mineral density values, that will give you a student's t-test map as the one that is depicted there for the femur, but you will get one for each vertebral body, and will tell us the locations where the bone mineral density values are different between 2 groups of subjects. So that's one big project that needs kind of a given good level of MATLAB programming skills. Could we go to the next slide, please? So then the second project that requires a little less MATLAB skills is a project in collaboration with Douglas Adams from the orthopedics department. And he has funding to do some gene knockout studies on rats. And what we want to do is basically to analyze the shape of these rats and try to identify effects on gene knockouts. And I have some tools to perform this shape analysis. But have never done shape analysis on these shapes, on craniofacial shapes of rats that look a lot more complicated than the shapes of a proximal femur or the shapes of a vertebral body. But then this would be basically adapting one code that would, the purpose of the code would be to establish anatomical correspondences between the shapes of the different rats, and then do some shape analysis with just basic principal component analysis. Could you click on one more time, please?
Sure.
And the last project then, not the last because and the third project is, we have images with MRI of the proximal femur with a very, very high spatial resolution such that you can quantify trabecular bone microarchitecture. And that's what you are seeing probably, hopefully in the second picture depicted with striations in red. So we are able to analyze those striations with different tools that we have. What we need to do, what we want to do is then to do voxel-based morphometry of trabecular bone parameters. And instead of doing voxel-based morphometry or voxel-wise comparisons of bone mineral density values, we want to do voxel-wise comparisons of trabecular bone parameters. And there is one additional step that has to be done in the middle in comparison to the QCT studies due to the lack of having continuous maps as those of bone mineral density. We have here interrupted maps of trabecular bone, and there is one step that you will need to do there to obtain parametric maps that are continuous. This project would be very straightforward because it would be a cascade of MATLAB functions that I have written. You would have to put a code just to be calling each one of them. And there is another project that today I was talking with a collaborator of mine, Dr. Shah from the Barbara Diabetes Center, and we have a good amount of data, imaging data, clinical data, glucose data that we can work with and get a project for in the context of type 1 diabetes and the musculoskeletal system, like shape analysis of the proximal femur or even the voxel-based morphometry technique. This project would be probably the easiest because this would be no development and would be just apply tools that I have in place. And that's my email. If you are interested in any of these projects, just shoot me an email and we can set up a Zoom meeting.
Great. Thanks, Julio.
Thank you.
All right, next is Bennett.
Okay, hi. My name is Bennett Chen. I'm the clinical nuclear medicine clinician scientist, and I'm an old guy. I'm a professor of radiology and had a lot of experience with research in a number of areas of nuclear medicine or molecular imaging and therapy. And this is a growing field. It uses highly specific ligands to bind to cell surface receptors or transporters, and we attach a radio-labeled radionuclide, an imaging radionuclide, to that ligand, and then we inject it into patients, and we can do PET imaging. So everyone knows FDG PET, but there's a tremendous, let's say, explosion of knowledge and clinical validation of these radio tracers. So the thing, it composes three parts. The first part is a binding ligand, which binds to the cell surface receptor. The second part is the linker. And then the third part is the radioactive part. It's a chelate. So the linker and the chelator is one part of the molecule that gives us the ability to image and to treat patients, cancer patients. So my field is oncology. And the chelator, all you have to do is add on a radiometal. And that radiometal can be a positron emitter, like a PET emitter, or it can be a therapy emitter, like a beta emitter, which delivers radiation to specifically that cell, that cancer cell, with that specific surface receptor. So in essence, it's a very highly specific way to image tumors, as well as to treat exactly those same tumors that you're seeing on PET imaging. Okay, so that's what the general field is. My particular interest is in AI and how to use AI to advance our field in patient care. So this is a slide of what we do in nuclear medicine imaging and therapy. Okay, we have PET emission, positron emitters on the left, and SPECT tracers on the right. So on the left is, I would say, the more contemporary research. And on the right is more kind of like the older style nuclear medicine, still great nuclear medicine. It's just what people think of nuclear medicine traditionally. So we have three main areas: neurology, cardiology, and oncology. And oncology is growing because it has these very, very specific molecules that can localize to tumors. And so that's why I call it theranostics, or imaging and therapy. Now, everyone knows about FDG. We do probably 95% of our tracers with FDG, but these are our new tracers that are coming up. And these are the ones we're going to apply AI to, essentially. So it's molecular imaging and therapy in oncology aided by AI. Now, I'm fortunate, lucky to be able to expand into different areas. And AI, I believe, is one of the very fast-moving fields that's fascinating, and I believe will be in the future in all of radiology. So this is what I concentrate on. So I'm gonna move this. You can't? Okay. Okay, so if Gordon can't do it, nobody can. AI, what we're looking at right now is automated lesion detection. If we have a program that can automatically detect cancers in our scans, it's going to help us. Now, I don't believe that at this moment it's going to be replacing any of us, but it can sure help us. And we have a lot of work to do. So this is a great project, in my opinion. Okay, so it's for detection and measurement, and our projects are in kind of more heavily related to programming. And if you know Python and you can code in Python, that's a great skill. You don't have to do that. Our projects are pretty, I would say, open, in that it's open to your imagination. We don't know how to exactly do this. If you know anything about coding, coding is just a way to represent your thoughts in a machine. And that's what really programming is. If you have that skill of coding, that's great. But how to actually detect, quantify tumors, that's really what we're trying to do. We are doing that, actually. And so it's not known what the best way is. And there are almost an infinite way to do these, to implement these ideas. So to me, it's very exciting. We right now have a small project with segmentation. It's a very simple project. But we are going to apply whole body AI to PET CTs. And this is the first paper we published. It was published this year, just recently. And this person, you may know, he was a class ahead of you. He is a medical student, now a radiology resident. He's doing his first year here, his transitional year. So he's pretty busy. But he actually happened to have a computer background, and was one of the smartest guys I've ever met. And so, you know, we had, I'll tell you the story real briefly, Cliff Notes. We had worked for about a year and a half on this project. And he was looking for a project, and he just brought it to the goal line. I told him when he first started, there's no way you could be the first author, because people, very smart people, have worked on this for a year and a half. And that's okay. And he was so good and so hardworking, and so that we had to make him, everyone said we have to make him the first author. So Mike Slosky is our physicist. Fuyang Zheng is our PhD scientist. If you notice from these presentations, you'll see that they're typically a combination of clinicians and PhDs, because we bring the ideas and the applications, and PhDs have a tremendous amount of skill and knowledge. And also have more time typically than some of the clinical people. So this is our data science person that does our AI. He's a tremendously bright guy. And we love working with him. He's just a wonderful person. Okay, so we also, our second area of projects are clinical physics projects. Nuclear medicine is heavily scientific, I would say. And we need to know a lot about the physics because it influences our ability to detect lesions. This is what we really want to do. We want to have the AI program to detect these lesions and to help us for two main reasons in clinical. One is if you are in clinical medicine, looking at a PET CT is typically 250 slices for the PET, about 250 slices for the CT, that's 500. And if you're looking at 2 old studies, multiply it by 3, that's 750. That's one patient study. And we have lots of studies to look at. It takes a tremendous amount of effort to go through those slices and look for things. And if we had a program that could help us, it could tremendously improve our efficiency and our accuracy. Okay, so that's our working hypothesis. The second use of it is nuclear medicine is extremely quantitative. It is the quantitative discipline of radiology because the amount of activity that you inject in a PET scanner can be quantified. It's very reproducible within 1-2%. And so we can quantify processes like glycolysis with FDG very reproducibly. And so we need to do that because we want to know how patients are doing. That's the first thing. That's what we do clinically. But we also use it for therapy development. Okay, so what therapy development could be our radioactive beta emitter targeted to that ligand. We know how well it's treating that tumor. That's one application. But there's a whole myriad of new therapies that are out. And the way to quantify how effective they are, typically with PET. It's done with FDG right now, but we have a lot of other tracers, and there's a tremendous opportunity there. So what else do I have? Okay, so we published 2 articles here. Mike Slotsky, our physicist, did these this year. Well, we've been working on them for a couple of years, and our focus is looking at small lesions because small lesions, easily less than 5 millimeters, can be detected with PET. In many cases, if we do it correctly, it can detect very small lesions in the range of 4 or 5 millimeters, which is really good for nuclear medicine. So we have to understand our radio tracers, gallium, F18, and how we acquire them, et cetera, to improve our ability to detect small lesions so that this will guide the therapy. And we need to know about reproducibility as well, a number of issues in small lesion detectability. Okay, so the project in this small lesion detectability is more of looking at lesion detectability in terms of signal noise ratio. And we have a couple of ideas about that. If you're interested in that, we set up a time and we can talk. And the last thing I'll say is your success will depend upon exactly what other people have said here, their level of interest and, and the match between your lab and what you're able to contribute and your interests. So if you're interested in nukes and some of these projects, we'll be happy to talk to you. And I wish you the best success. All right.
So John, are you on?
Yeah, I'm on.
All right, go ahead. I'll advance your slides.
All right. Thank you, Gordon. Welcome, everybody. Thank you for logging on here tonight. I'm John Lindquist. I'm one of the interventional radiologists. I work with Dr. McLennan. And I want to talk to you about a couple of case reports that I've got that would be available if anybody is interested here. I think this is the low-hanging fruit. This is the warm-up for some of the more involved projects that have been presented at this meeting, and there's some awesome stuff being done in radiology. I'm really excited to hear about some of these other projects, and what the purpose of these case reports is to get you familiar with the process of doing research, to get you guys a flavor, and to take you through an easy, brief literature review and take a project from a presentation form into a journal submission. So I want to take you through the process. I also want you guys to get something out of it. And so this would be a first author journal publication for you guys if you're interested. Gordon, we can go to the next slide. So I've got 4 different projects I want to present here today. And each one of these, again, is a case report. Each one of these has already been accepted to a national meeting for presentation. 3 of these were actually accepted and presented at the European Society meeting this year. And so that's where we're starting. We're starting with cases that are presentation worthy and have been accepted. So the first case here is a case of a Watchman device. A Watchman device is a left atrial occluder device. It's placed by our interventional cardiologists. It's deployed from a transseptal approach. So they take a catheter from the venous side through the right heart. They puncture through the cardiac septum, and then using a combination of imaging modalities, size a device, and then deploy it to exclude the left atrial appendage. And the reason they put these in is we've got patients that have atrial fibrillation that are at risk of developing thrombi in this location. And by excluding it, you can end up reducing the risk of embolic stroke. And these patients can get off their anticoagulation. Well, we had a patient where this procedure went wrong. The device ended up embolizing into the left heart, was bouncing all over the place. And we ended up using a number of different retrieval techniques, and ultimately we pulled this thing out of the aorta using an endobronchial forceps. So a nice case, again, accepted at meeting, and we were able to get this patient taken care of without opening their heart up, which was on the table at one point. All right, next one, Gordon. The next set of cases here are related to DVT and PE thrombectomy methods. This one was a patient that was recently postpartum, had some endometritis, and ended up developing an iliofemoral DVT. We used a new device called the Inari clot retriever, and we were able to get this removed for this patient. The crux of this case report is that we were able to use a purely mechanical method, and in a patient that has potential infected clot, some of the other methods that we use to break up or dissolve clot can end up sending a lot of these infections into the bloodstream and can make your patient profoundly septic. And so this would be more of a proof of concept that this is possible, that we can remove clots even in patients that have potential infection. Next one.
That's your result.
That was our, yes, we had a very nice result. Here's number 3. This is a patient that had May-Thurner syndrome, which is where you have sandwiching of the vein between the iliac artery and the spine. And for these patients that have clots related to that phenomenon, we can put stents in. Well, this stent was unfortunately a little bit deeper than than we wanted. And this patient ended up over the years developing a contralateral DVT. And that DVT was intervened on him initially, but the patient had chronic occlusion of the right iliac system eventually. And this is what we see when we have chronic occlusion. The patient has got all sorts of tiny collaterals that are crossing the pelvis and has drainage of her right leg predominantly through the open left iliac stent as a result of this chronic occlusion. She was symptomatic and had an acute on chronic thrombotic event. And so she came to us for a procedure, and we ended up using the same clot retriever device called the Inari Clot Retriever, and we used some methods to protect that device. So this report is describing those methods that you can use to take this device through a stent. We also put up tandem balloons and we ruptured the existing stent. And then we were able to end up with a very nice result. And that's what we ended up with, which is what it should look like. We've got very nice channels here at the end of the day. So that's number 3. Next one up. This is a patient that was 6 weeks post a single lung transplant. And this patient was out working on his car and something didn't feel right. He walked into pulmonary rehab with oxygen saturation at 80%. And they did a CTA and found that he had a giant PE in his transplanted lung. And so this is a pulmonary angiogram. This shows that there are a lot of branches that are missing, and there's a big clot that's lodged in the pulmonary artery. And so we used a device called the Inari Flow Retriever, and this is a large bore aspiration catheter that we can use to remove clots from the lungs. And this is what we got out. And you can even see the femoral branch point here in the clot. So this was a dramatic example of use of this device in a patient that had had a recent lung transplant, was not a candidate for thrombolytics. And so the message there on that case report is going to be PE in lung transplant patients, and then use of large bore aspiration mechanical thrombectomy for that patient. And then finally, I'm actually not going to talk about this one because I've got another student that's already writing this one up. So
Gotcha.
I'm going to cut it off there. Thank you very much, Gordon.
Sure. All right, and then Dr. Mughari, I think was just in here. Okay, well, I can come back to his. He had more slides than, I'll just talk about mine. And then if he comes back, that's fine. He's got some bioengineering stuff. So I've got a couple of projects. I'm the chief of interventional radiology. I'm also the vice chairman for clinical research. So getting you guys involved in clinical research is really a primary aim of mine. But one of the goal projects that I have that really needs some help from a student is to actually go out to the dental school and start talking to dentists. We actually have developed already a tool for assessing their knowledge about a disease called hereditary hemorrhagic telangiectasia, in which patients get pulmonary AVMs, they get telangiectasias in the mouth, they get AVMs in the rest of the body and liver and mesentery. But the most common presentation is an oral telangiectasia, which looks like a lot of other things in the mouth. The most likely person to find that is a dentist or a dental hygienist. So the idea is to provide a standardized education package for dentists in the dental school. And we're going to do 20 dentists get educated, and 20 dentists get the same amount of time period to go look up HHT. And then we're going to look over the next 6 months, what's the difference in referrals to our HHT clinic, because they're all going to get that contact information. We're going to see if the formalized education process, we also have standardized quizzes for them to take. So it's all about the impact of education related to the dental community. If it works out that we can raise awareness, this is fodder for a subsequent grant to the HHT Foundation to see if it's worth developing generalized curricula for dentists. The imaging of pancreatic veins, I have a student working on that. This relates to our goal of doing a clinical trial on transvenous chemotherapy administration for pancreatic cancer in the pancreas in non-resectable advanced pancreatic cancer. Pancreatic veins come off the portal vein in the portal venous system, but nobody's ever bothered to catalog that. And we're going to end up having to puncture the portal vein and find our ways to these veins. So we're essentially going to try to create an atlas from triphasic CT scans that'll give people a description of where these veins can be found, where they can be segments that are long enough and interesting. So I think Mike Kwong in the first year is working on this project with me. We have a couple of students working on evaluations of gastric tubes and transesophageal gastric tubes in patients with malignant ascites. There's a clinical quality improvement project that we're doing with gynecology oncology. There's a big push to put feeding tubes in patients with ovarian cancers, and some of them develop very large amounts of ascites. Ascites can predispose to really severe infections and is considered a relative contraindication to a gastrostomy tube. So that going through the esophagus is better, but there are complications and difficulties with that. So we're going to give patients the opportunity to choose what they want to do and then measure patient satisfaction and any complication rates. And then some of the residents are also working on some case reports related to those procedures. And then the last two are really what I'd like to look at with respect to some of the processes in the hospital and the practice itself as chief of the section. We have some data on issues related to delays in patient care related to insurance authorizations, the throughput efficiency in the interventional system through modifications of the Epic ordering system. We're in the process of changing some of that. The other question is whether the telehealth visits have increased the overall volume of procedures in the IR section by implementing them in the time of COVID. These types of process issues there's a number of them. I've talked to our administrator. My phone number, that's my cell, call me if you want. And the email's at the bottom. And I think I'm going to go back for Dr. Moghari.
Hi everyone, thank you for having me here. I am Mehdi. I'm a physicist at the Department of Radiology and also associate professor in the Department of Radiology. And this is the research that we would like to have your help on. We would like to see, this is the title of our research, which is in utero brain development in fetuses with congenital heart disease. So basically, this is our hypothesis. We would like to know and to investigate whether in fetuses with congenital heart disease, there is a correlation between the expected pattern of in utero brain blood supply and the severity of neurodevelopment impairments. Basically, our hypothesis is that if there is a fetus with severe congenital heart disease, the blood would not easily flow to the brain. Therefore, the brain should not develop as the normal fetuses. So we would like to show that here. So this is our methodology. So we would like to retrospectively identify 50 to 100 fetuses with normal brain by MRI. And then we would like also to recruit 50 fetuses with congenital heart disease. Then we would like to divide these fetuses to two subgroups, class A, where we expected to see severe reduction in oxygenated brain blood supply to the brain, such as left outflow tract obstruction or transposition of the great arteries. We know that the blood flow would definitely doesn't go to brain as the normal fetuses. And also we would like to look at the class B, where nearly normal oxygenated brain supply exists in fetuses, like other congenital heart disease, like dextrocardia that we have. Then we would like to do brain volumetry on normal class A and class B, and then we would like to statistically compare the brain volumes. And that's why we need your help here. So to do the brain volumetry, we will provide you with 3D data sets of the fetal brain. And we would like to have your help for manually segmenting the brain lobes, left, right lobes, left lobes and different regions, then those segmentation would supervise with our radiologists just to make sure that the segmentation is valid and these are the regions that we are interested. And then we calculate the brain volumes. So this is our brief explanation of our project. We will appreciate your help as having you as our first author or co-authors of any result that comes up from this study, and also we will involve you to R01 grant that we would like to submit. If you have any question, you can ask me. I'm Mehdi, and also I have a collaborator, Dr. Mirsky. I don't know if he's available here and he would like to add any clinical input to this project. David, are you on?
I'm on, and Mehdi, you summarized it beautifully. It's a lot of exciting work that Mehdi and Alex's lab is doing, and so this kind of research can dovetail with a bunch of different projects. But no, Mehdi, you summarized it beautifully.
All right, that's great. So that's what we have, and now it's time for discussion. So for you guys in the room, a lot of us are here. If you've got questions for folks that are on the line, speak up. And if those of you on the line, students on the line, go ahead and ask questions. We'll spend 5 or 10 minutes, having some discussions. And yeah, I'm going to pull open the chats. I'm going to that way I can actually look at them, because it's hard to do during this. So Sarah likes it. And then there was confusion about seeing it. So if you want to type a chat, that's fine. But otherwise, speak up online or speak up in the room, and we'll direct you to the right person. If you want to split off to people too, that's okay too. We're going to be a little low key here, and then Bennett's going to take those of you that are here on a tour of the Research Imaging Center. So, anybody have anybody they want to chat with while they're on the line? Or are you going to all contact us later? By the way, I will keep this recording and the PowerPoint. I'm going to send it to Tessa, who manages our website, and we'll be placing this material on the website for the radiology department in the research section. And that way it's going to be available to the medical students, and we'll reach out through you guys to try to get it out to the rest of the medical school so that that link can be provided to other medical students who might be interested. Comments, questions? Yeah, we did all right today. Especially trying to figure the technology out. So, but yeah, it's a great, this is a cross section, and really a small cross section of research available in the radiology department. We sent out emails a couple of times. I think the Children's Hospital, I don't have all the contacts on, because I just used the radiology all email address, and it is probably about 10 years out of date, because I was getting a lot of declines from people who have retired. So, but that, this is a try, after COVID, to try to get us back engaged and actually doing some good work that'll help you guys go far in the world of radiology. So, all right, well, thanks. If there's no discussion, we'll go have a quick tour and then let everybody loose. Thank you very much. Are we allowed to join the tour? Of course.